That was brilliant. Thank you so much. Okay, we are very, very close to the end now. So I am going to announce the last session that I'm talking about today. So next we are going to have a fireside chat with ICHOM. So I'd like to welcome to the stage Dr. Stefan Larsson, who is going to introduce his panel. Come on, we can do better than that. Please welcome to the stage. Thank you.
So what we would like to do now is to reflect a bit on the past 2 days on the conference, and asked the panelists to think through a few things on the meeting, what they've taken with them from it. But before I do that, I'd like to introduce the panel. So to my furthest right is Patrick Conway. Patrick is the CEO of Care Solutions, Optum. He was previously the CEO of Blue Cross Blue Shield North Carolina, and was also the leader before that of CMMI. And you met with his successor, Liz Fowler, earlier this morning. Then we have Elizabeth Theisberg, who you all know very well by now, who gave a wonderful dinner speech yesterday, who wrote the book together with Michael. That is the foundation for all the work that we've been discussing these 2 days. And then we have Kelly Peisch, who you may have seen in one of the previous sessions. She's the Global Director of Clinical Quality and Survivorship for Movember, so the patient advocacy group. Those of you who try the mustaches, they were all her fault. And then we have Martin Ackerman, who's the board member of Diabetes, this diabetes organization in Netherlands and now beyond that works on the value-based healthcare principles, and he's the head of medical affairs, value-based healthcare, Northwestern Europe for Medtronic. So we have a diverse group of panelists who've been part of the discussions. But I thought I would start with Elizabeth. You and Patrick were both at the original ICHOM meeting 10 years ago. And maybe, Elizabeth, to start with you, what do you see as the main differences when it comes to the meeting and what has been discussed between this meeting and the one 10 years ago?
So, thank you. At that first meeting, I was there virtually, which in those days meant just listening in. There was no beaming in, no Zoom meeting, but there was a major hurricane, so I was virtual. And we were at that point trying to figure out, we didn't have any standard sets. We were trying to figure out what should standard sets be, what should be measured, what do we need to do? And there were debates about whether they should be about process or whether they should be about outcome. And it was really starting from an empty page. And now we have standard sets for many, many things. And it's a major change, and it's a huge contribution. When I think about the work that our team does with clinical organizations, they usually start by looking at ICHOM standard sets and saying, which of these measures should we use? Which of these measures can we drive significant improvement in? So it's become a starting point for major transformation efforts. And the difference between an empty page and a full book of options is just incredible.
And Patrick, you managed to get yourself through the storm and into the building. I remember you standing there. I don't remember if you were wet or not, but you were there. If you think about where the sort of outside of ICHOM world, the value-based healthcare, the world of discussing healthcare quality, what has happened in these 10 years? What are the key things, would you say?
Yeah, I think we've made a ton of progress over the last 10 years. So I was chief medical officer at CMS and about to be leading CMMI at the time. And if you think about that, it was a debate about process or outcome measures. And so we were in charge of the measurement for Medicare and Medicaid, and ICHOM and others pushed us, and we tried to execute on this on outcome measures across programs. Still work to do, which we can come back to, but really pushed on outcome measures across programs, standardized quality measure sets, working with public and private payers to align measures. And ICHOM was really foundational in that work, and I think helped shape our thinking. And then, as you mentioned with CMMI and the payment models, I think we've now made a ton of progress in real value-based payment in the United States, but in other countries as well. Where at that point we had essentially 0% of payments in Medicare and real value-based payment models where the provider's accountable for total cost of care, quality, and experience. 4 years later, we had over 30% of payments in Medicare, over $200 billion, over 200,000 signed provider agreements through the Innovation Center. It's now, as I'm sure Liz Fowler shared, at about 50% with a goal to get to 100, based on the foundational work by Elizabeth and Michael Porter on value-based care delivery. So I think ICHOM and people on this stage have played a major role in that transformation. And I'm excited about the next 10 years, which maybe we can talk about later in the panel.
Okay, so I'd like to then turn to the 2 days. And maybe start with you, Kelly. If you think of the different sessions you've been part of, what you've seen, what have been maybe things that have surprised you? And what have been things that have, you found really exciting and inspiring?
Thank you, and thank you for allowing us to be here and as a part of this panel, sitting here representing every incredible mustache grown around the world, and also the almost 250,000 men with prostate cancer represented with the ICHOM sets in mind around the world in our work. And so as I think about representing such a specific condition and population, I think one of the most exciting things the last few days is just realizing how amplified this work has really become, how even when we are all representing a specific condition or disease, or in my case, cancer, I think that when we share in the same room the challenges that we face with implementation, with setting things up, and now this big shift into the action that comes off of this work, I think it's incredible to learn from each other, but I think the similarities, some I think maybe were to be expected, but also maybe others surprising in how much relevance there is across different parts of the world, conditions and disciplines. And so I think it's just been incredible to think about that maturity, and then to think about how the sets were created with that patient outcome in mind, and we see those pictures even in the sets. And now that we look at some of the maturity with what the sets have been able to achieve, I think that takes on a whole new meaning for how we can use this information, how we can use what we're learning to really define value and to really define and work together on the outcomes that matter most for patients.
Martin.
Yeah, I think I was thinking about 10 years ago. 10 years ago, I was leading the purchasing department of the largest health insurance company in the Netherlands. And at that time, we're discussing, why is it necessary to measure outcomes? What do we do with minimal, norms for complex care? And I think we have beyond the why now. And I think we also are much further beyond the what do we need to do? And I think that's a blessing. Now we're much in the phase of, how we're actually going to do it. And you see, reflecting on the last 2 days, there's a lot of discussion on how you see everybody struggling, making progress. And I think that is just, a perfect example of, how difficult it is, but also how much stamina it needs to move the needle in this case. And I think that's what I have seen. I'm happy that I've seen a lot of discussions about digital platforms, the use of AI, although AI is a container, term, but there's also discussion on what it actually means and what it actually can do. But, when I look at my iPhone, I see now, I think, iPhone 14, we're in the 14th model of the iPhone, but if I look at healthcare, sometimes we're using the Nokia, so that is puzzling me. Why are we doing that? But I think that's also something that, is now on the agenda, so I'm hopeful that we'll make progress and we can share some new insights in the next few ICHOM meetings. And I think that is just amazing. If you look 10 years back, again, 10 years, I was not in Boston, but I knew that ICHOM was moving into a space that was actually untapped. I think it's tremendous. And yesterday I had a remark that I said in the forest of healthcare there's no bamboo, nothing grows fast. But I think that ICHOM over the last 10 years has grown, and the fact that after COVID we have 500 people from all over the world in Boston doing this is for me an example that we're really moving, and we need to really move. I heard Professor Lee say, Don Berkovich actually had a quote, you need to move to the space where you can see there's progress. On the other hand, I think also people in this room, we need to tickle a little bit more and knock on the door, because we don't have that much time. So I would also break a leg for something that we are more persistent on driving this as a group, and not only move towards where there's fertile ground.
More forceful.
Yeah, we need to be a little more forceful. And I think that's on us. That's the leadership component.
Right. Elizabeth, surprises, inspiration.
I think the inspiration comes actually from all of you, from all of these sets that you've contributed to creating, and then from all of the projects that you've done from there. So we have all of these points of light. We're actually super aware of that in our work at the University of Texas, because we created a one-year master's degree, and our students tell us that every week they see another example of these amazing transformations, these amazing improvements in outcomes for the people being served. And so there are just tremendous examples out there in this rich array of individual projects. And so the opportunity from that is to move from these individual projects to creating new frontiers, to connecting those individual projects. So it's not just that they've done something extraordinary in place A or something extraordinary in place B, but that in different locations and different organizations, in a connected way, they've defined a new frontier. Because that makes the old level of outcome achievement, that makes the old levels of inequity, that makes the old results unacceptable, because now there's a new frontier. So I think that thinking in terms of that opportunity of creating a new frontier of outcomes rather than just the individual projects is what I find so exciting. And if you think about it, you've heard talk over this last, actually over the last years, but certainly over the last couple of days, of are we actually achieving this movement from volume to value? And our team thinks it's actually the wrong question, because it suggests that we're downsizing. And actually what you want instead is to take these inspiring examples of high value care that are getting better outcomes for more people, right? And take those to scale, scale those up. So we actually want to move from value to volume so that we achieve scale, and high value care becomes the norm. And I think that's where the excitement of this is for me.
Much of the discussion day one was around system change. Let's go from islands of success to system change, make it ubiquitous. Patrick, you came from a session just before this on implementation with a set of different organizations discussing what it takes to change. You've led some transformational change in your years. Some thoughts on that maybe?
Yeah, I will challenge the room, but with optimism. So 10 years ago, I was in my 30s and had energy and was here. I'm now in my 40s, a little less energy.
Already?
And we have to change the system faster. Like, I'm really worried about the pace.
Yeah.
And I'm worried about the pace because there are people that will fall through the cracks. So the businesses I lead today will serve over 50 million people, many of them in fully accountable relationships. But like the discussions we have with our teams is, how do we go faster? How do we serve them better? How do we make the cycle time faster, learn faster? And it's on us. Like, it's groups like this that need to drive that change. So I think we're beyond the what, the et cetera. It's the how, and then it's how do we go faster? I wasn't planning to do this either, but I will. I told this story to my mental and behavioral team the other day. I work clinically a walking distance from here and take care of kids in the hospital. And I had a 14-year-old a few months ago who had called over 100 outpatient providers with severe depression, started trying to use substances to self-treat, eventually walked to the 3rd floor of her building, which was only luckily 3 stories tall, jumped off, fractured both of her legs. We had now fixed her legs, and we're still working in the United States of America to get her outpatient behavioral care, insured in Medicaid. Horrible. And this, I get calls every day for our mental and behavioral business that are patients, families that need help, that our system is not helping them systematically. And so it's one, hopefully tangible example that calls us as in all the countries we represent, because mental and behavioral health is universally a challenge. We have to do better, and we have to do better faster for those people that we serve.
I think that was a takeaway from the lunch yesterday that I felt very strongly about. We need to move faster, but we need to get policymakers to have the guts and so on to step up. Yeah. And so the question asked at that lunch was, which is the constituency which will be influential enough to put pressure on the politicians to actually make some of these things mandated? And Kelly, my thought was immediately, it would be the patient advocates. I mean, a very large share of all the voters are, one way or another, a patient. So if we can mobilize the patient to say, this is not okay, you have to do something about it. Right? There may be other better constituents, but I'd like to hear your thoughts on that. And maybe Kelly, your organization has actually been very forceful in trying to, drive some of these things through. What are your thoughts on that?
Yeah. I think an immediate response is that we have to do better, and even we ourselves think that there's so much work to be done about how Movember can have a stronger influence and really take some of the work, especially when we think about the convening and being a global catalyst of collaboration and knowledge exchange, that we have an obligation to make sure that every single experience, and then thinking about what that means across health systems around the world, that patients' voice has to be driving some of this change. I think there are concrete and very specific examples of where this has been successful, but I think if we allow the patient voice and what they need most kind of fall quiet in the midst of these other priorities, and we don't come together at a healthcare provider, at a workforce, at a training point of view, at a health systems point of view, and give those patients a platform, and I wouldn't say give like it's a gift, but if we're not thinking about this inclusion from the beginning and along this process, I think we fall short and we do a disservice to our patients. And so whether that's priorities that we set at an international level and thinking about what some of those consistently are and coming together to create more forums to share and to drive change, I think all the way down to the how has to be within a country or within a health system, and maybe that's provincially or state-led, but we have to come together, I think, to not work in our silos, but to amplify and to think about ways that that patient experience and that patient voice is heard. And I do think there is a volume factor to this, and I would say in Movember's experience, we have the immense privilege of thinking about and hearing from people all over the world, which then allows you, in kind of a hub and spoke kind of way, to understand where some of these are consistent and where they vary and where that's important. And that diversity is critical. But I also think being able to connect those dots is one of the biggest obligations patient advocacy organizations have, and making sure that there's a seat at the table for them, including in forums like this, is going to continue to be so critical.
When we opened the meeting, there were 3 buzzwords at the top. It was meet, be inspired, and make it happen. And I'd like us to have the last part of this discussion to be on how do we make it happen. We have many of you in the room are leaders in your respective healthcare system, one way or another. My wife said, it's fantastic, there's so many young people at the meeting, which is great. You may not all be leaders, but you soon will be. But what I would like us to discuss as we close is, what can we do as individuals? What can leaders do, or should leaders do, to speed this up? Patrick, you said 10 years, a lot has happened, but far too little has happened. And we are in a downward spiral in many ways. So we have to make change happen. What is required of healthcare leaders individually and collectively to change so that we accelerate the change and not incrementally continue on the current pathway?
Yeah, my point of sharing my age was not to show I'm older, it was that I want it to happen before I'm done with my career. It's getting closer, so we got to get going. I'd say a couple things. In our own systems, whether you're a leader at whatever level, I shared earlier, my first leadership role was one unit in a hospital with a nurse, and how do you make it better for 15 patients coming through that? At whatever level, how do you drive change in that system? How do you really push, et cetera? So that's sort of the system aspect. This policy aspect, I think I would sort of amplify. I think we're often too tentative in policy environments. So I've said in other forums, in the Innovation Center, I would have done mandatory models sooner. There were a lot of political reasons that we had trouble getting that done, but it was a better design. We knew that. It just took too long politically. And even now, there's a dearth of models coming out of CMS that have been mandatory, as an example. So I think we need the policy will, if you will, to break through. The third thing I said in a forum with a lot of people concerned about their unit economics the other day, we got to stop worrying about our own unit economics. And I work for a for-profit company. This is not lost on me. But a radiation oncology model in the US that gets killed, that if you really look at why, it's unit economics. It's people don't like their dollars taken from them. So how do we realize that there's enough dollars in the system, whether it's the US or another system? It's actually how we use those dollars better, which relates to the two on the policy. So those are some of the things I would call out. For ICHOM and the people in this room, I do think outcomes measure is a foundational principle, that we're beyond the whether we should do it. So it's now how do we embed that across our various systems.
Martin, you want to go next?
Yeah, I do think that also when you see the Minister of Health from the Netherlands speaking about that 50% of all the healthcare delivered should be transparent, then he also needs to put the measures in place to actually execute on that. You cannot only say that you need to move in it. And if I hear Peter de Bey speak about all the good work that he does, but he is actually struggling to have good conversations with health insurance company, coming from health insurance company myself, yeah, they also have complexity, but then put the complexities on the table and see what kind of complexities that we need to deal with. So I'm also an advocate to put the payers here more on the stand and see what is needed from your side to move it and get that transparency from them as well, because there is no table. There's only one table in healthcare, and it's a round one, and we need to figure out how we deal with the issues that we have. So I think there's still a pond that is a little bit untapped, I think, so we need to get them on board, and I'm aware that there are different countries, different payers. And also the word payer, the payer just pays the bill. I think if you are in purchasing or procurement, you actually need to know what you buy. And I think the most procurement or purchasing organizations do not have a clue what they're actually buying and what kind of quality they get. So I think that's also the need for transparency on outcomes for certain procedures. And you need to start somewhere. So we did it in diabetes with I'm happy with my contracts with the insurance companies, but that's only me. And I think that needs to be scaled up in a much broader sense, not only in the Netherlands, but also in other countries. So that needs to come on the table, and it's not a voluntary discussion, I think.
Elizabeth.
I keep thinking we need to give louder voice to our outrage. You think about what we've seen in the pandemic, and not only have we seen health outcomes as headlines with millions of deaths, and we've seen headlines about health inequity and disparities, and we've seen headlines about poor primary care and poor care for people with chronic diseases. We see all of the indicators now showing that spending in healthcare is about to rise again, and with person after person pointing out that trust in healthcare is going through the floor. There are so many things that right now should drive our outrage, and our outrage should lead us to push change. I mean, we desperately need change. If we're going to do better for each and for all, we're going to have to transform the system. And as to who, everybody, every actor can do more and can do it faster if they so choose. But we're going to have to prioritize getting to a better place. And so maybe we just have to be louder about the outrage. Having told more of my personal story to a couple hundred of you last night, what I know is that everybody in this room has some sort of scary healthcare story that they've been through, or some gut punch healthcare story that they've been through. We all know it needs to change. For us, for our kids, for our parents, but for our neighbors and for the world. I just think we should give voice to the outrage and go for it.
We started the conference yesterday with Suzanne sharing her patient story, and I'd like to close the meeting, Kelly, with you. As maybe not the outraged personally, but as a representative of those who are, what do you want leaders to do? What do you think are the priorities that we should see from leaders in healthcare around the world?
I think a question we should challenge ourselves and leaders to answer, especially in outcomes work, is, are you reaching those who need you most? And to really answer that question quantifiably and qualitatively, I think it's a great step to listen and to co-design, but we have to remember, as is all of this work, it's not linear, it's cyclical. And so are we regrouping? Are we doing that again? Are we responding to the real world? And so I think that the challenge to do better, there's no greater moment than for us to elevate and collaborate together this work so that we can go faster in a really smart way and in the way that will be the most meaningful to the outcomes that we're trying to drive and to achieve.
Thank you. And with that, I want to thank the panel for your wonderful reflections on the meeting. I'd like to invite up the ICHOM leadership team for us to share a few thoughts of optimism about the future, and then we take the meeting to a close. Thank you so much.
Thank you.